like, share, and subscribe here on Oncology Tube to get notifications when similar videos are available.
Indeed, you had an ASCO plenary on Hodgkin's lymphoma of all things, so that's what we're mostly going to focus on today. These are my disclosures. I actually forgot to throw in some consultancy I did for Genentech this week. Okay, so I'm primarily going to focus on SWOG 1826. This was a plenary not only at ASCO, but it was also a plenary at ICML, or the International Conference on Malignant Lymphoma, which happened about 3 weeks after ASCO. So this was a big deal for general oncology, but also a big deal for lymphoma as well. So this was a randomized study of nivolumab, or Nivo-AVD, versus brentuximab-AVD in advanced stage Hodgkin lymphoma. And so the rationale for this is, in general, over the last about 2 years, we kind of finally moved more or less from ABVD for everybody to brentuximab AVD for the stage 3 and stage 4 patients. Many people moved with the original data from Echelon 1, and a few people finally moved and changed their practice after we got the overall survival data. But we still haven't cured everybody. And one thing that's always been really interesting to me about Hodgkin's is, as adult medical oncologists, we actually approach this very differently than our pediatric colleagues. So one of the themes of this study was collaboration, because we actually pulled in the pediatric group, and they actually ended up accruing about a third of the patients into this study. We also know that while brentuximab AVD has improved progression-free survival and now overall survival, we also know it is not a benign regimen. People get way more neutropenia and way more peripheral neuropathy. So we thought we could do better. I'm not going to spend much time here, but basically we know that checkpoint inhibitors are this is the one lymphoma, or one of the very rare lymphomas, where they're incredibly active, and we have good data in combination with chemoimmunotherapy to suggest that this is a reasonable comparator arm for a randomized phase 3 study. So relatively straightforward study design, randomized phase 3, 1-to-1, Nivo-AVD versus brentuximab AVD. Everybody was on the day 1 and day 15 schedule. If you were on the BV arm, GCSF was mandated. If you were on the nivolumab arm, it was up to the treating investigator. You can see the stratification factors here, including the age, IPS, and there's these weird little quirk about whether or not radiotherapy was intended. This came from the pediatric people, who use a lot more radiation than we do, and in the end you'll see that probably none of this really mattered. But there was this whole thing about, if you thought you were going to radiate the patient, you had to declare it up front when you randomized the patient. So this data actually got reported early because it met the accrual early, and the SWOG DSMB looked at the data and said, oh, we actually need to report this based on the data we have so far. I'm not a statistician, so I'm just going to leave this be. So here's the eligibility criteria. So all patients above the age of 12, so there were patients from 12 to in their 80s on the same study, which almost never happens. You can see the other criteria here as well. If you had interstitial lung disease or pneumonitis, you couldn't participate because we thought that there'd be an increased risk with the checkpoint inhibitor. If you had peripheral neuropathy at baseline, since that would be an issue with the BV, and then active autoimmune disease because of the checkpoint inhibitor. So we had almost 1,000 patients on a Hodgkin study. Like, that's incredible, right? This is again, just a lot of this is kind of amazing just because of the effort that went into it in terms of collaboration. So we have almost 1,000 patients on a Hodgkin study, and you can see at the end of the day, we had 483 patients on the Nivo arm and 473 patients on the BV arm. In terms of the baseline characteristic, we actually probably enrolled kind of a high-risk group. You can see actually the majority of patients were stage 4 disease. About a third had a high IPS score, and about a third had bulky disease. So this is fairly representative of Hodgkin's, and we definitely did not cherry-pick the good actors here. Median age on both arms was mid-20s, which is about right for Hodgkin's, although worth noting a little bit younger than the median age on Echelon 1, which was the mid-30s. So AEs of interest. So we talked about how from brentuximab, this is really myelosuppressive. I was trained, with ABVD to never give growth factor. You don't need it. It causes more bleo lung. BV is the complete opposite. You absolutely have to give growth factor prophylaxis, or you run into a lot of problems. So either way, there was more neutropenia on the Nivo-AVD arm, but it didn't really translate to more febrile neutropenia, which we'll get to the next slide. And you can see, though, that only about half of the patients on the Nivo arm got GCSF, when it was nearly 100% on the BV arm. But again, it didn't really translate to more febrile neutropenia. In fact, in both arms, febrile neutropenia was relatively uncommon, as were sepsis and infections overall. So certainly, if anything, maybe a trend toward decreased infections on the Nivo-AVD arm, but again, relatively small numbers. Peripheral neuropathy was the other major AE we wanted to look at because, again, one of the reasons to think about moving away from brentuximab is to get rid of the peripheral neuropathy. And you can see that the amount of grade 3 peripheral neuropathy was exceedingly low on the Nivo AVD arm versus about 8% for the brentuximab AVD arm. This is just a bit of a further breakdown. I won't spend too much time here. So then the other thing we obviously have to think about here is the autoimmune toxicities, right? You guys actually give way more checkpoint inhibitors than I do, so you can probably teach me about the autoimmune toxicities of checkpoint inhibitors, but we certainly looked for them. It was relatively uncommon to see any evidence of hepatitis, hypothyroidism, pneumonitis. All of the AEs in regards to autoimmune toxicity were relatively low, except for a few cases of hyperthyroidism and hypothyroidism, all of which were relatively low grade. In terms of treatment discontinuations, they were lower on the Nivo AVD arm. No one stopped because of progression or relapse on the Nivo arm. Deaths on treatment were generally low, but lower in the Nivo AVD arm. Fewer patients completely discontinued their extra drug, so to speak. So 11% of patients discontinued the nivolumab and 22% discontinued the BV. And at the end of the day, that radiotherapy thing didn't matter much because almost nobody got radiotherapy. There's a lot of PROs that were collected as part of this. There was also some correlatives with circulating tumor DNA, and all of that will be coming over the next year or two. But at the end of the day, here was the primary endpoint. Primary endpoint here was progression-free survival. So you can see that indeed the one-year progression-free survival was improved for Nivo AVD over brentuximab AVD. Early follow-up median is only about a year, but still really encouraging. Was there any particular subgroup that did better with the nivolumab? The short answer is probably not. Obviously, it'll take a little bit more time for this to mature, but the forest plot here all kind of skewing towards the left, favoring the Nivo AVD arm. So far, there's been no split in overall survival. Again, it's early and it's Hodgkin's, so it's probably going to take a long time to see a difference. It took us 6 years with Echelon 1, and I would also caution that maybe it won't even happen just because we've gotten so good in terms of salvage therapy with Hodgkin's. So at this moment, there's no change in overall survival, but again, median follow-up only 12 months at this point. So these were the conclusions that were given actually as part of the Lugano presentation. So Nivo AVD improved PFS compared to brentuximab AVD. Nivo AVD was incredibly well tolerated. Most of the toxicities were in the grade 1 area, and very few patients ended up discontinuing the nivolumab therapy compared to the brentuximab arm. Almost nobody got radiation, which is, I consider, a win. Obviously, we need more follow-up to make sure that this holds, that this PFS benefit is durable. The data we have so far from other regimens in Hodgkin's or in phase 2 regimens looking at checkpoint inhibitor with AVD or chemotherapy backbone suggests that this will hold, but of course we have to see. And again, this was one of the first times we ever looked at adult and pediatric patients in the same study. And so it may be that we're moving towards a place where we are harmonizing therapy between our age disciplines. So this is what happened in the US over the last couple of years. Our friends in Europe are still thinking about things a little bit differently. So this is from the Lugano meeting. This is from the German Hodgkin Study Group, and they are the people who are still championing BIACOP. Why? Because they've cured so many people with it. Why don't we like it? We don't like it because it's really toxic, it's hard to give, and it gives people infertility and secondary malignancies. So we haven't been thrilled about this in the US, but it is worth talking about because people were kind of examining these studies side by side at the same time. So they looked at your kind of standard BIACOP versus this BRCAD, which is basically their version of incorporating the brentuximab into the chemotherapy backbone. And much like when we took brentuximab and added it to AVD, you can see that there is an improvement here in PFS for the brentuximab containing arm versus the standard BIACOP. Relatively long observation time, 40 months, so chances are if people are going to relapse, they probably have in this period of time. So I suspect this is probably where our European colleagues are probably going to move when it comes to advanced stage Hodgkin lymphoma. So this came from a debate that was kind of done at the end of the Lugano meeting, where there actually were several studies in advanced stage Hodgkin's presented at Lugano. So there was 1826, there was this one we just looked at with the BRCAD, and there was this other study looking at this dose-dense ABVD, which had to do with actually increasing the amount of anthracycline that was given as part of the ABVD regimen, and the schedule was a little bit different. With this whole hypothesis, right, higher dose, more frequency, maybe can improve outcomes. So that study also met its primary endpoint. So basically, more was better in that particular study. So we've got now 3 different approaches, all kind of beating their standard comparator arm. We've got the Nivo ABD, we've got this dose-dense ABVD, and we've got this BRCAD. And so where are we going to go? What are we going to do? And so I think ultimately a lot of this is going to be at the eye of the beholder, and I do think geography is going to play a huge role in this. You know, obviously, the way we've approached this in the U.S. is different than how they've approached it in Europe. And so I think at the end of the day, we're seeing strides towards curing more people up front, which is fantastic, but we're seeing maybe geographically or some differences in how we can get to the same outcome. So is Nivo AVD the future for advanced stage Hodgkin's? I think in the U.S. it almost certainly will be. In fact, they're looking to kind of figure out how to maybe make this registrational and submit it to the FDA. I think it's important not only from a progression-free survival standpoint, but really from a side effect profile. You know, these are often younger patients. These are people we're trying to cure, and these are people we would really like to not walk away from their chemotherapy with peripheral neuropathy. I don't think this is going to happen, particularly listening to the way the discussions that were happening in Lugano. I don't think many of our other colleagues are going to be moving to this Nivo AVD approach. And the rest of the world, you know, obviously we're very lucky to have access to all of these drugs, and it may be for the rest of the world something like dose-dense ABVD is going to be huge because they're inexpensive drugs that are easy to get and easy to give, and that's at least another way that in a more resource strapped setting you might be able to improve outcomes. I had 2 quick things if I had a moment that I was going to touch on. This also came from Lugano. This kind of was one of the practice-affirming studies for me. So this was patients who with primary mediastinal lymphoma, so we're moving a little bit away from Hodgkin's, but still some biological similarity, where these were patients who got their kind of induction therapy, whether it was R-CHOP or dose-adjusted EPOCH, and if you reached a metabolic CR at the end of your therapy, this suggests that you do not need radiotherapy. For me personally, this has always been my practice, but I'm a big fan of sparing people radiation to the chest. So this, I thought, is good to see this data to kind of affirm that practice.
Like, share, and subscribe here on Oncology Tube to get notifications when similar videos are available.